experiential, how patients experience the disease. And that emphasis is ongoing. Okay, so that's related to reductionism, is basically the idea that you can reduce the description of all disease into that mechanism of action classification. So the emphasis is heavily on genetics and the microscopic environment, those types of things. Whereas the holistic approach is more experiential. Okay, the reason I bring that up is because I wanted to build up to evidence-based medicine, which is apparently the standard of practice. It's not always available, but my impression is that that's the gold standard. Okay, so the big advantage coming from this model is that there's an emphasis on randomization. So getting rid of your selection bias. And there's a whole strata for how you quantify what's valuable evidence and what is not, with expert opinion being ranked at the bottom. So the idea is researchers in the 90s found that there was too much emphasis on just opinion without reference to trials and outcomes. So the idea was to get agreement. Okay, so we've already really covered most of this, so I'm going to skip forward. Okay, so some critiques. It really requires randomization, and we've seen some difficulty with actually achieving randomization in practice. So there's also the possibility of having many different factors responsible for an outcome. So the analogy they gave in the article was tea guessing. So this person claims to be really sensitive taste buds. It can taste the differences in many different types of tea. So they put her to the test and she gets 7 out of 8 correct. Well, should they assume actually she really does have a very good sense of taste? Well, it's possible that she has an earpiece and someone's feeding her the answers. That's a logical fallacy of the affirmation of the consequent. So if A, then B, and you have B, you can't assume A if there's more than one cause for B. Okay, there's also finite population size. We touched on that already. So how do you randomize if your sample size is 10 people? It might be kind of hard to, Okay, I think we also touched on the test population versus sample population. If your intervention is meant for the geriatric population, but you exclude them from your trial because they have mortality from other causes, how effective does that translate if your study group is 40 to 60, but your intervention is planned for 60 plus? Okay, also when you're going from a statistical model, you have to make a logical inference that what's good for the group applies on an individual level. So it seems a logical assumption to me, but pragmatically, how else are you going to map the genome for every patient and match their genetic risk factors? It seems impractical to me. You guys have any thoughts on that? Just out of curiosity. No comment. Okay. I don't have much else to be interactive, so just trying.
Doing good.
All right, so the strength, I think, really comes in when you have both the statistical and mechanistic explanations. So the mechanisms of action are still unknown in many disease states, but when you have, I think that's sufficiency and explanatory scope. So if there's statistical evidence in addition to the mechanistic view, that to me seems much stronger. I think that's the ideal case. I think pretty much everybody agrees. Okay, so ready to go back through. This is just my interpretation of Dr. Field's analysis outline. So is it relevant? Can the interventions produce the effect in question? Are the methods valid? And the results. Okay, so my paper was the pancreatic resection. So does adjuvant chemotherapy, chemoradiotherapy, or just chemotherapy improve survival outcomes? And they didn't really set endpoints beyond that, as far as I could tell, just which is better for survival. And I took their word that it was unanswered because I didn't myself go through the literature and see, if it's apparently there was debate and the results have been inconclusive, so they wanted to go back and look further. Okay, so there aren't that many patients that have pancreatic cancer that's surgically removed. The patient group seemed to me to be quite similar to the target group. Only about 10% of cases are even eligible for surgery. So, I mean, it seemed to me that they're working with what they have. So, okay. I'm going to cover in a couple slides. The way they broke down their organization seemed a bit strange to me because chemoradiotherapy seems like 2 treatments to me. And maybe Dr. Field has a comment on that, I don't know, but if you're looking to control for one treatment versus another, it seems odd that you have chemotherapy in 2 of the treatments, right? So, like, we'll go on to see that they concluded that chemotherapy was effective, but chemoradiotherapy had deleterious effects. So it seemed somewhat conflicting. Okay, we mentioned before about selection bias and patients being treated or analyzed as the group they were allotted to versus what they actually had. So it turned out that more left the chemotherapy group than the chemoradiotherapy group. And to me, that may end up saying that one group may have preferred healthy patients versus the other group. Because if I'm a patient and I think, well, I have a really severe case, I need to get the most aggressive treatment, I may opt out of the less aggressive group. You see, so by that virtue, by selectively opting out of those treatments, you may end up with the chemotherapy group having more healthy patients to start with. Okay, yeah, so they mentioned this, the lymph node and smaller tumor size. They made a note of it in the paper, so I thought it was curious that they didn't control for it, because that seemed like that may play a significant factor in confounding the results, where if you have a distribution in one control group versus the other, having smaller tumors significantly than the other group, especially with a small sample size, only 52 survived to the end period. That seems significant to me. Okay, this is just a visual breakdown so you can see how they allotted the groups. And really they compared those that had chemotherapy versus no chemotherapy and chemoradiotherapy versus no chemoradiotherapy. Okay, so for the purpose of the analysis, it seems strange to me.
It's very strange. Go back to the 4x4 thing for the 2. So you can see there's some people who got no treatment after surgery. And so they were always in the no chemoradiotherapy, and they were also in the no chemotherapy group of the final analysis. And then there's chemoradiotherapy, so they were in the chemoradiotherapy group. Then you've got the assigned to chemotherapy, so they were also in both sides. And then you've got the people who were assigned to both, who were also in both groups of the final analysis.
How do you blind a study where the patients are getting chemotherapy? Or
Right, this one
radiotherapy,
cannot be.
Right?
No, this is randomized and stratified.
Well, can you like pretend to just give them saline, everybody saline, and run through a trial and pretend that?
Sham radiation.
Yeah,
That's a heck of a lot of work.
it is. Yeah. I was thinking about that.
The other thing that I didn't mention is it's really also important to have like equipoise before you run these studies, right? So at this point in time, really people did not know if you needed to have anything after surgery for pancreas cancer. The surgery itself is a huge ordeal, lots of time in the operating room and lots of time for recovery. And unfortunately, these people do very, very poorly. So at the time, we just really didn't know. So it wasn't that they needed to be blinded, because I think there really was like equipoise in the fact that, you know, it was sitting comfortably that you could have somebody go through one or, you know, any of these options, and nobody really even knew what to expect would be best. That makes sense. But yes, this is crazy. This kind of sums up the craziness of this trial. So soak that part in. You can figure out who they're finally analyzing. Good on you.
I had trouble. Okay, so this is why we can't just take correlation at face value, because if you look at this, it looks like, well, chemotherapy had a significant improvement versus no chemotherapy, whereas chemoradiotherapy did not.
I think chemoradiation ended up doing even worse than like observation.
It did, yeah. But
Are
I
you
think,
going to tell us what they did for the radiation treatments?
oh, it was 20 gray in 10 fractions. I forget the chemo treatment. It was more like a burn and cruise for the chemoradiotherapy, whereas a sustained dose for the chemotherapy.
So it was 20 gray over 10 weeks, or over 2 weeks, 10 fractions. Then you got a 2-week break, and then you got it again. So a total of 40 gray over, 6 weeks with a 2-week break in the middle. And so this is what they're drawing on for radiation harming, being worse than observation. Does anybody think that plan might be flawed?
Has the study not been?
Oh, this study has been, this is notorious.
They said it was due to toxicity from the treatment.
Yeah, so people used to be so worried about toxicity. Now we know, doing a split course allows tumors to repopulate, makes them angry, makes the bad ones grow faster. And in pancreas, when we're treating these patients, we do at least 50 gray in over 5 weeks altogether. So the dose is too low. The program doesn't make any sense. And actually, they tell you in some part of the study that the radiation plans weren't reviewed centrally. So this was conducted over, I don't even remember how many countries were involved. So you've got to imagine there's people out there doing all kinds of crazy stuff. But this was big publicity, right? New England Journal of Medicine, radiation hurts people.
Was there a question back there?
I was gonna ask what the rationale was for the 2-week break in the middle, just to
It used to be done all the time because of concern for side effects. Yeah, until people realized, it was done in many different cancers, until people realized that was actually hurting people worse than some nausea and vomiting.
When was this done?
Published 2004.
Oh,
So it was done in the 90s mostly. In Europe. Europe no longer uses radiation in pancreas cancer. It is,
how was the chemo schedule? that one? I forgot.
I think this chemo is just fluorouracil-based chemotherapy. It's pretty standard. I mean, now we do use a better chemo. And now they do too. They've run all their subsequent trials with just one chemo versus another. They completely dropped radiation.
Because of this.
Mhm.
And I think this is just further reiterating the confusion between how they broke up the groups. Okay, I think we talked about that already. So several other publications, basically, even at the time and afterwards, weren't able to show a significant improvement with chemotherapy. So yeah, that's what I've got. Any questions? All right, Sam.
Okay. How much time? Okay, I can get it done in 10 minutes. Sure. So today I'm going to be talking about the Z0011 clinical trial. Hopefully, mine's a little bit more interactive. I don't mind being interactive. If you have questions or something, just shout them out throughout the whole thing. So a quick look on the clinical trial. The problem statement was to determine the effects of complete axillary lymph node dissection on survival of patients with sentinel lymph node metastasis of breast cancer. I'm sure 50% of us at least don't exactly know what that means. So some quick definitions. The axillary lymph nodes are the lymph nodes underneath your armpit, and the sentinel lymph nodes are the lymph nodes that are just outside of that tumor that the tumor area kind of drains into. So traditionally, people can go in and biopsy these sentinel lymph nodes, and you can detect if they have some kind of microscopic metastatic disease. And it's kind of been looked at, is that an indicator that they're going to have reoccurrence, or it's going to metastasize elsewhere, and things of that nature. So in short, they wanted to know if it's necessary to remove all of your armpit lymph nodes if you have a low grade tumor for breast cancer. The accrual of all of the patients ran from 1999 to 2004. The last follow-up was in 2010, and the results were finally published in 2011. So meanwhile, I kind of already touched on this. The ALND was historically a very common surgery that breast cancer patients got. It was kind of under the assumption of, well, just in case. It was kind of looked at, I think by 2005, seeing that if your sentinel biopsies were negative, then you probably maybe didn't need it. But as far as looking in, if you were kind of had 3 or less lymph nodes positive, do we still need to do this removal of all of the lymph nodes? The reason why anybody would care about this is because you get a lot of morbidities when you remove all of these lymph nodes underneath your armpit. My mom actually had breast cancer, and she had this done. They kind of did it without her consent too. And she deals with lymphedema and things like that. So it was an important thing to look at for these guys to do. So now we'll start getting into the details. They looked at patients with a range of diseases, T1 to T2, so kind of stage 1 cancer. They had to have negative axillary lymph nodes, but then they had to have 3 or less positive sentinel lymph nodes during their biopsy. And then they had to have planned to have a lumpectomy and whole breast radiation. That may or may not have happened. And then it also, I wanted to just kind of highlight that the group that had the surgery, 66% of them had estrogen positive receptors and progesterone positive receptors as well, which probably most of us, that doesn't mean too much, but that can, that's a very specific indicator of when and if you're going to have a recurrence. So it's kind of skewed in that direction. And also, as far as patients that were discluded, if you had adjuvant chemo was given at the doctor's discretion, so you may or may not have had that as well, which can definitely affect things. And then they excluded all neoadjuvant treatment and patients who had mastectomies. All right, so the goal was 1,900 patients, and they would perform the analysis after 500 deaths. They ended up with 856 patients due to low accrual and the fact that people just kept living. So obviously, red flag. I see some eyes kind of pop out. 420 of those patients received the dissection of their armpit lymph nodes, and then the 436 were just observed. The age range was about 24 to 92. The median age was 55, and I think the median age for the dissection group was 56. So relatively comparable. And then the follow-up was only 6.3 years on average. So we'll look a little bit further at their patient population. So they started out with 891, and then they had 35 patients withdraw from each group. That kind of left them into their intent to treat group. But if you look a little bit further, they had about 50 people in each group that were ineligible, and that actually didn't apply to their set sort of criteria. So not only did some of these people get lymph node removal and some of these people didn't, some people had the incorrect number of positive lymph nodes. Some people had gross extracapsular invasion, so the tumor was kind of outside of that T1, T2 range. I don't know what you guys think. I think that's pretty messy. But and then they have like 13 and 6 other reasons why. So kind of got a little messy there. Then we kind of look into the results. So 103 ineligible patients were included because they did go that intent to treat route, which I suppose has some validity. But when I kind of look at this, I sort of think,
Probably because they didn't do a good job up front.
yeah, no, no.
Desperate for patients.
Yeah, very, very, very desperate. So they do quote that a more conservative analysis was done with them excluding some of those ineligible patients, and they reported that they were about the same when they just analyzed the intent to treat sample. So yeah, no qualitative difference really, or so they say, because they only reported the intent to treat numbers. So the conclusion, they said at 5 years, there was no difference in terms of overall survival between the two groups. That also includes local recurrence as well. And then as expected, the patients undergoing that dissection had increased surgical morbidity, and I think it was 75% in the surgery group and 25% in the no surgery group. So this might make your palms a little bit more sweaty. This is actually a landmark study that changed a lot of the way that we treat people in our field. People jumped on the results and they said, okay, if you got less than 3, then we're not going to do the surgery anymore because they said it's fine. So what issues jump out to you guys? I have them kind of listed, the ones that came to my mind, and I know they're kind of obvious, but anybody have any thoughts on issues that make them upset and frown? Yeah?
All the ineligibilities.
Yeah.
That were like upfront, just like missed or something.
Yeah.
In
Yep.
cases where it went messy, like you said, and not their attention to detail maybe was not.
Yeah. Who knows what happened? Okay, well,
Do you guys think 6 years is long enough for a 24-year-old with breast cancer? 5 years.
no, I agree. So, obviously, 856 is truly much less than 1,900
Which brings
patients.
their power, right?
Way down. So I didn't look into why they wanted that much and if that was going to have a statistical effect or something like that. I mean, I'm not going to make necessarily
Yes,
the
that's how
claim.
they said it, is that was the number they needed to show a difference.
Oh, I do want to say in 2005, some people started writing up some regulations or recommendations, and they quoted this paper having shut down in 2004, saying that, well, they tried, but they aren't going to be able to answer their original questions. Therefore, the investigation is over. And then somehow in 2011, they still posted the results anyway. So I don't know. It's really funny to me and kind of scary. So is 6.3
But
years?
do they actually state that in their paper? That
State.
this is one of the limitations?
Oh, yeah.
I mean, if that is so,
Yeah,
it's kind of fair to.
It's run by surgeons, and this was very widely adopted by surgeons. So breast surgeons basically stopped doing axillary lymph node dissections. Are you going to talk about the radiation thing?
No, I'm not.
So what radiation oncologists started doing when their patients were on this trial was doing what's called high tangents with the breast treatment, because you were only able to radiate the breast after lumpectomy, which is what we always do. But radiation oncologists started sneaking up that top border
To get the lymph.
to get the lymph nodes. So if the radiation oncologist, this is an example of not being blinded, knew that their patient was on the sentinel node option, they were actually covering the lymph nodes with the radiation. So it's really left us in our field with a pickle as to what to do, what
Yeah.
Because surgeons basically just started like never doing axillary lymph node dissections after this.
Yeah, super, very odd. And even if the results are somehow valid, it's questionable to say the least. So 6.3 years, I would assume it's not long enough for a 24-year-old or a 30-year-old or anything like that. Maybe the 92-year-old.
Maybe the 92-year-old.
But breast cancer is
She might
not.
have not needed any treatment.
No, I know. 92. Who is this lady? So is diagnosis important? The hormone receptors, that can actually, as I kind of mentioned, and you can probably speak to it, if you have an estrogen positive tumor, then a receptor positive tumor, then your recurrence likelihood is beyond 6.3 years. It can definitely extend.
They can live for
Yeah.
ever and ever.
So,
And breast cancer can recur 20 years after treatment.
yeah. So if the
One of
whole
those.
point,
And you could give chemo if you wanted, you could give hormone therapy if you wanted.
Yeah.
So
yeah, if you want to know if something's going to have a local recurrence or you're going to survive that after that 5-year mark that we always set, I mean, you got to give yourself a fighting chance to make it realistic for people. And the applicability to young women has been kind of questioned because of this very short time frame. And it does not address patients undergoing neoadjuvant therapy, which my understanding is that's
very common.
yeah, this is extremely common. So, if people are going to stop doing the surgery because they don't want to give people lymphoma and all these things, well, I don't know, a fair margin of these people, the study doesn't apply to. So, okay, so what would you improve?
No, we have to do this quickly because there's a meeting in this room.
Oh, okay.
at 11.
So I'm going to guess that it's a lot. I will say that in 2007, they had a continuation. I guess it got a little so they said longer follow-up was necessary because the majority of the patients had estrogen receptor positive tumors. So at a median follow-up of 9.3 years, great going, guys. That's so much more than 6. They found that their results were consistent with 2011 results.
I find this room has been highly critical of follow-up. They did the study in 2005. They have published in 2011. You can only get a 6-year follow-up there.
Right. No, absolutely.
So are you not supposed to publish anything for another 10, 15 years after the study?
I think.
So let's be realistic. Let's not be too critical that follow-up was only 6 years. And it seems like what they're doing is right. After 2017.
Continue to do your follow-up. No, absolutely. This is great, but
it seems like they're published to publish. They're publishing just to publish because it's not giving any results to the field that are meaningful at all.
Yeah, publishing is fair, but the fact that it had such an impact on the way that people decided to treat with not that much solid footing is really the criticism.
And I guess Emma can speak.
I think the power is the biggest thing. They really didn't meet their accrual goals.
Okay.
I do agree with you. I think we deserve to know what happens in the long term for sure. But yeah, it's a very hard study to draw a lot of conclusions from. And I think what radiation oncologists are trying to do is pick up the pieces and figure out what we're supposed to do.
Because in the end.
But yeah, we're not trying to be critical. We're just, pointing out that we have to be careful in evaluating these results because Samantha's right, the conclusions have been widely publicized and highly adopted. So we have to know what they're based on and what we need to do that's right for the patients.
But when I see a paper like this with some messiness, looking you are dealing with old people, cancer patients and all that, and follow-up is always a problem. Because on the flip side, I've seen a paper in which the results are really very, very, everything comes in a nice neat bowl. And the results are really nice, but no one else can reproduce those results. So I kind of question what did the pro people do to massage the results such that you actually get really nice results.
Oh,
I was
absolutely.
thinking about this comes from not from radiation oncology, but